Welcome back to our final day of the TIPQC annual meeting. I hope that you have enjoyed it as much as I have. Again, my name is Brenda Barker. I'm the Executive Director at TIPQC, and it has been absolutely our honor to host you and all of these wonderful speakers and workshops throughout these last couple of days. At this time, a couple more housekeeping notes in case you've missed those. During the usual in-person meeting, we like to engage with you, one of the great joys of the year. This year, not exactly the same, but do use that engage button and make some comments, ask questions. The engage plus symbol is located at the top right corner of your screen. If you need assistance, click the green help button located at the lower right-hand corner for tech support. We would also love to encourage you to jump on our social media platforms. Be sure and join those if you haven't in the past. We have Instagram, Twitter, and Facebook. We'd love to see you following those. We'd even love to see you use the hashtag TIPQC2021 and tell us about your experience, chat in some thoughts. We'd love to hear from you on that platform. Finally, in regards to CME, none of our speakers today have anything to disclose. CME credits are available for you if you click on the CME file, and all the directions are there. As I've said the last couple of days, unfortunately, our CNE is not available during this year's annual conference, and we really hope to have that available for you next year. If you are a nurse wanting to receive credits, you can use half of your credits through the CME, so feel free to go ahead and utilize those. Special thanks to Vanderbilt University Medical Center for providing our CMEs at no charge this year. If you missed any of the annual meeting sessions, these are available for 30 days in this very same platform, so just log back in and even feel free to share those with colleagues who could not join us. You might want to show this in a team meeting, and you're absolutely free to do that. You might want to listen to one of the workshops you weren't able to attend, so jump in and join us in that platform, and we hope to hear from you after the conference, any questions or thoughts or concerns that you might have. Again, we'd like to thank our sponsors for all their support throughout the year and our partners across the state and nation. Please feel free to click on their tiles, learn more about them. Some have videos and other information you might find interesting and helpful, and it may help to know who those partners are that TIPQC works with. So please, as you listen, go ahead and chat in your thoughts and any questions that you have with the blue Engage button on the top right hand of your screen. Again, welcome to Day 3. Dr. Jessica Young, the TIPQC Maternal Medical Director, will introduce our first speaker.
Hello, welcome to our final day of the TIPQC annual meeting. We are so thrilled that so many of you have joined us for day 1 and day 2, and I'm sure that day 3 is going to be equally as engaging. We're going to start off with a poster. The poster winners will be announced this afternoon in the closing ceremony, so please be sure to hang around for the closing ceremony. In addition, all poster presentations are available to view in the poster tile of LeaderPass. So take a few minutes to review those. And remember, this platform will be open for 30 days after the conference closes today, so you can access presentations and anything that you've missed. Let me introduce our first poster presenter today, Dr. Jahan Ellis from Regional 1 Health.
Hi, my name is Jahan Ellis, and I am the Community Program Coordinator for Childbirth Services at Regional 1 Health. I am here today to present my project, Develop a Virtual Model for Childbirth Education and Community Outreach to reach expectant mothers and their families during COVID-19. COVID-19 has forced the cancellation of all hospital birth facility tours, group classes, and community outreach events. The question was, what if we found a new way to provide education? The aim of this project was to redesign the childbirth education program to provide virtual learning and connect parents with community resources. I started with an internet search in April of 2020 to find visually graphic presentations and childbirth education resources that could be incorporated into my existing PowerPoint to increase engagement without the capability of hands-on demonstration. The search yielded a resource provided by Plumtree Baby that provides graphic PowerPoints at a cost, whereby you are able to incorporate your own personal slides. Also, with assistance from our IT department for webcam and WebEx access, along with the buy-in from community agencies to distribute the information. Data was obtained through SurveyMonkey, social determinants, attendance data, and submission requests. The findings resulted in the total number of participants for classes and in-person tours scheduled in 2019 was 258, with 147 who attended the classes and or a tour. In comparison, for the year 2020 with COVID, the number scheduled for classes and requested tour info only was 295, with 113 participants who attended the virtual classes with 92 no-shows. The responses showed that 34.38% were not so confident at the beginning of class, whereby 81.25% were very confident or extremely confident at the end of class. The results in this study were just a stepping stone to better understanding the needs of the participants and the impact of COVID-19. Overall, 75% of the class said that it exceeded their expectations, and 25% stated it met their expectations. It is reasonable to conclude that virtual childbirth education has been well received in the community, and there is a continual need. For future works, I will continue to provide monthly virtual childbirth classes when in-person learning returns to campus, and to increase the participation rates by improving upon the perception and need for childbirth education in 2021. Again, I would like to thank you for allowing me to present this information to you.
Thank you, Dr. Ellis, for that presentation and sharing with us how you have pivoted to do virtual childbirth education during this pandemic. We will all now go to a unique interactive workshop with Laura Vandernoot-Lipsky. So please head to the workshops below to join us for this interactive session called Care for the Caretakers. So just click down on Care for the Caretaker tile, and I will see you over there.
Hi, everybody. Welcome back to the final day of TIPQC annual meeting, and thanks for joining us back on the main stage. I hope everybody made it back. Let's hear from another poster presenter. I'm going to introduce Dr. Rishika Sakaria from UT Health Science Center.
Hello, everyone. My name is Rishika Sakaria, and I am a second-year neonatology fellow at the University of Tennessee Health Science Center in Memphis. We started a QI project to improve the rate of red reflex documentation in the infants discharged from our NICU. Red reflex testing is vital for early detection of vision as well as potentially life-threatening abnormalities. AAP recommends red reflex assessment as a component of eye evaluation in the neonatal period. According to our current unit policy, all infants less than 32 weeks of gestation and less than 1,500 gram birth weight receive an ROP exam at 4 weeks of life. We performed a chart review on patients who did not have an ROP exam during the hospital stay and were discharged during the 2 months prior to beginning this project, which showed that the documentation rate for red reflex ranged from 15 to 29%. There was a definitive scope of improvement. Our aim was to increase this rate to greater than 80% by the end of January 2021. We realized that we could improve this rate at 2 time points, at admission and at discharge. We recognized potential interventions to improve the documentation rate at these 2 endpoints. Potential interventions at admission included reminding the residents every month during their NICU orientation and having visual reminders using notes on every computer in the unit, as well as improving the availability of ophthalmoscope in the unit. Interventions at discharge, including bedside nurses reminding providers to document the red reflex at discharge if it was not documented during admission, as well as introducing a discharge checklist for the NNPs and the residents. Data was collected from qualified discharge patients at the end of each month, and this data was shared with the faculty and nursing so that improvement could be tested. The documentation rate improved to greater than 70% on an average during the 5 months post-intervention. The improvement was seen both at admission and at discharge, but was greater at admission. In October, we made the ophthalmoscope available in the unit rather than in the NNP office where it was previously housed. This was associated with a significant improvement. We show that even small interventions can actually lead to a culture change and a significant improvement in the red reflex documentation. We now plan to integrate the red reflex documentation in the discharge checklist of the hospital EMR so as to further improve this rate. We will continue to monitor the documentation rate to ensure increase and eventually sustenance of the improved rates. Thank you.
Thank you, Dr. Zakaria and the team from UT. As a reminder, we want to hear from you. Please submit your questions in the chat section. Click on the blue Engage symbol located at the top right corner of your screen. We'll try to answer as many as we can after our next presentation. So it is my honor to introduce Dr. Lizzie Harvey, the Senior Maternal Child Health Epidemiology Program assignee from the CDC to the Tennessee Department of Health Division of Family Health and Wellness. And also, great pleasure to reintroduce Dr. Morgan McDonald. Dr. McDonald is the Deputy Commissioner for Population Health for the Tennessee Health Department. They are both dear friends to TIPQC, and both are very accomplished. So we're super excited to hear from them, and we appreciate their leadership and guidance for the well-beings of Tennesseans for each and every day of their work. Dr. McDonald and Dr. Harvey?
Good afternoon. It's great to be with you again this afternoon, and really want to thank Laura, and if for those of you who maybe weren't able to make the workshop previously, certainly would give a plug there, and has actually quite a lot of relevance and connection to what we'll be talking about this afternoon. Over the next 30 minutes or so, Dr. Harvey and I are going to talk really about the direct impact of COVID-19 on the health broadly to the maternal and child health population in Tennessee, some of the data that we are seeing really across sectors, and then Lizzie's going to give more of a deep dive into surveillance of COVID-19 in pregnancy and infancy in Tennessee. So I woke up on Monday morning and had really, I think a lot of us have had kind of a reliving of some of the trauma that we've experienced over the last year, and just realizing that really coinciding with a great number of celebrations that we have had over the course of this past year at TIPQC, we also, I think, do ourselves well to pause and acknowledge really a lot of the trauma that we've lived through over the last year, personally and professionally. I know it was the second and third, the night of the second and into the morning of the 3rd of March, where we had the terrible tornadoes in Nashville and Cookeville, Wilson County as well, and the loss of life there, as well as really the resilience that we've seen across the state. And then it was just one day later on the 5th of March where we had our first case of COVID-19 identified in the state. And what a world of difference over the next year, really the journey that it would take us on. And so I think certainly having this moment to really pause and reflect on what we have all endured, again, personally and professionally, and then how do we rebuild out of that, and particularly in the context of our professional roles, and in really promoting health to the full extent for women and children across the state. So a little bit of a glimpse of some of the indirect health impacts that we are seeing really related to COVID-19. Our provisional data in 2020, again, this is not final data yet, but some of the things that we are starting to see is an excess in all-cause mortality by about 10,000. So 10,000 more people died in 2020 than what we would have expected looking at the average mortality for the years prior. About half of that was direct COVID. So in December, when our files closed, we had about 5,000 COVID deaths, so deaths due to COVID, and then about 5,000 that were other causes across the spectrum. This was largely in adults, and particularly senior adults, but certainly impact generationally, we've felt across the board. Provisionally, we're seeing an increase in homicides generally, and particularly in youth homicide, that we've seen signals, particularly in the western part of the state, and it has been quite a cause to action from a lot of our trauma partners in West Tennessee and across the state, really looking at it impacts potentially of kids being out of school, of unemployment in families, additional stressors. I will say that our provisional data is not all negative. It looks like actually we may have a decrease in infant mortality in the state, and particularly in the western part of the state. And so we hope that there'll be more good news to come. But certainly we are all grappling with very real realities in multiple different sectors. A little bit of our mental health data. What you're seeing in front of you is actually Essence data. This is our surveillance system that we use for ED presentations for multiple different causes. This particularly is signals that we're seeing in youth suicide and suicidality presenting to emergency departments across the state, so both children's hospitals and non-children's hospitals. And this is a month-by-month comparison. And those blue columns are 2019, red is 2020, and then green is 2021. And particularly in that second half of the year, so the right-hand side of the slide, seeing increases 2020 over 2019 in presentations for youth for mental health concerns. And then particularly in the first part of 2021, those green bars on the left, significant increases over 2019 and 2020. That February data, second column is still incomplete. So this data was pulled really about halfway, 2/3 of the way through the month. So certainly seeing an impact really increasingly over the last few months in child mental health. And then kind of zooming out a little bit outside of the health and mental health spectrum, unemployment and leaving the labor force has been obviously a focus of the state and of the country. Over 1.1 million people have left the U.S. labor force, but particularly 850,000 of them were women. And we think largely because of school being remote largely, and the impact that that has on families and on women in particular. And then additional unemployment data, what you're seeing is really a very short-term comparison, September of 2020 being in the green, January 2021 being in the blue. And so we do see improvements across the board, both for unemployment in men, that's the left-hand column, and then subdivided in different types of women. But you do see overall much higher impact of unemployment in women than in men, and particularly minority women as compared to men, although that is improving the fall compared to the spring and early 2021. And then school status really affecting women, and kind of back to that slide 2 slides ago. But over half of K through 12 students in the country began the school virtually. And I think we in Tennessee have been on the forefront of getting kids back in person for particularly some equity reasons that I'll look at. But obviously that remote schooling certainly does impact women's economic achievement even more than men. CDC has recommended a number of safeguards to get kids back in school safely, and we've partnered across the state with Department of Education to really implement mask wearing and cohorting, distancing kids to be able to do this as safely as possible. And we know that when those measures are in place, that transmission is rare. A couple of slides really looking at equity in education. This is actually data from last spring that compared educational achievement for schools on average, that 1920 school year compared to the 3 years prior. And this is a breakdown by reading at the top and then math, and the grade level breakdown of math below that. And so what you see is on average, all commerce scores are significantly less than that school year 1920. But looking at schools that are predominantly Black populations on that left bar, so the black dot, the educational achievement, even just for last year, is significantly less than white schools that are predominantly white, which is the blue bar on the right. And then this is data from the fall of this year, looking at who has access to in-person learning. And far and away, the access to live teachers is higher for schools that have a larger white proportion of students as compared to Black or Hispanic population of students who are about twice as likely to not have access to in-person learning. And so when we then extrapolate that educational disparity into long-term impact on really economic attainment across race and ethnicity, the impact is even greater. And so what you're seeing in front of you is the relation between unemployment and educational achievement. And so the blue line in the middle is overall unemployment rates across the last couple of decades. And of course, we see a huge spike on the right, 2020 to 2021 related to the pandemic. And then the breakout there, the top line, is for individuals who do not have a high school equivalent, and then below that, those individuals who have higher educational achievement. And so the unemployment rates, as we would expect, are significantly higher for those who do not have as great a level of educational achievement as compared to those who don't. And so long-term, we're really thinking quite a lot around really widening gaps and how do we minimize the widening of gaps in educational and economic attainment. And then, of course, ACEs and how we approach that comprehensively as a state. And so the time to act certainly is now in thinking about how we approach individuals in our own trauma-informed practice. And then that early screening and referral to resources is all the more important now. And just want to make sure that certainly in the perinatal period, we are referring to evidence-based home visiting and through Department of Health care coordination. And so for those families that are at risk, who have a higher level of both medical needs and social needs, every health department has the CHANT care coordination program that's available. And that is just through our website, tan.gov/health. You can put in the search CHANT, and there's a number to call and a referral form that can be used when we're happy to come alongside you, really to make sure that families do have as much support as possible in navigating this time now more than ever. And then also thinking about our language as we are trying to reflect positive and protective experiences as a buffering and really creating that brain space and healthiest development opportunity for kids, particularly in 0 to 3, but all throughout childhood and adolescence, of course, as well. And then the importance of making sure that we're coordinating behavioral health services and then advocating for educational and employment opportunities and investment, particularly in violence prevention, as we're certainly starting to see those signals across the state. And so now it's with great pleasure that I will turn things over to Dr. Lizzie Harvey, who is going to give more of an in-depth look at how we are looking at the impacts of COVID-19 from a surveillance perspective in pregnancy and infancy. So Lizzie, I will turn things over to you.
Thank you so much, Dr. McDonald. So I'm now going to switch gears and dig a little deeper into what we're doing in Tennessee specifically around COVID-19 and pregnancy and what we're seeing in our data. Next slide. So almost a full year ago, back in April, states were contacted by the CDC to voluntarily participate in surveillance of pregnant women and infants to better understand the epidemiology of COVID-19 and to also inform clinical guidance. Next slide. So to be included in this cohort, we were really looking at pregnant women who are SARS-CoV-2 RNA positive through a lab-confirmed test in at least one specimen at any point during their pregnancy, who reside in Tennessee and have a pregnancy completion date in 2020. Next slide. So one of the first ways we were able to identify COVID-19 in pregnancy was through the case report form, or CRF. And the CRF provides up-to-date data, not only on infection status, but as you can see here in the middle of the screen, among the many other variables that are being collected, there's also a pregnancy indicator. And by having more timely information on both pregnancy and COVID-19 status, the CRF is helpful in giving us a real-time look into the burden of infection for this population to inform public health action. But we'll see as we move forward in this presentation that there are some considerable data quality issues that we needed to address. Next slide. So again, our main source of COVID-19 data comes from our case report form, or CRF. But it's really important to understand that the CRF data is one piece of our larger COVID-19 pregnancy surveillance project. So in addition to lab and demographic data from NBS, seen here in orange, we also link our CRF data to birth certificates and fetal death records, as well as maternal death records. We pull in data from our ICMS, which is our newborn screening data, as well as abstract data from medical records. And those can include indicators such as birth abnormalities, the reasons for cesarean or emergency deliveries, as well as other treatments. Next slide. So we'll start by sharing information we learned from looking at our case report form data. Next slide. So before jumping into Tennessee data, I did want to share that national COVID-19 pregnancy data are collected and updated weekly on the CDC website. And as you can see nationally, as of March 1st, there have been over 73,000 cases of COVID-19 in pregnant women and 80 total deaths. Next slide. So during the fall, we really worked hard to release a similar public-facing pregnancy dashboard that highlighted data from the CRF, including total cases and active cases, as well as demographic data, including the burden among Black and Hispanic pregnant women. So we released this dashboard in October and really expected to update it monthly. But we really started to see some data abnormalities in early November. Next slide. As we're well aware in this pandemic, things can change pretty quickly. And the top chart shows what we were seeing in our epi curve among cases in Tennessee, which, as we all know and remember very clearly, there was a huge surge happening at this point. But the bottom is an epi curve for what we know about pregnant cases. And what we can see is we saw no similar surge in our pregnancy data. We found that there were both system issues and case interview capacity issues contributing to this discrepancy. The pregnancy notation on the CRF generally comes from the case being interviewed. So with a high surge of cases, there was a lag in cases being assigned and interviewed, and pregnancy status just wasn't able to be obtained. Next slide. So in December, Tennessee adopted the CDC prioritization protocol, which closed out cases with specimen collection dates later than 6 days to focus their efforts on newly diagnosed cases to stop the transmission. But as we can see in this process, we realized that the data quality issues with conducting surveillance on pregnant COVID-19 cases through the CRF was just not reliable, and we needed a better way to understand the burden in this population. So in the blue line here, you can see the missing information in the CRF for the pregnancy indicator among women of reproductive age over time. And what I find striking is that in December, that reached as high as 90%. Next slide. So I'm going to quickly go through some of the data that we've learned through our linkage of the CRF data to our provisional birth and fetal death records. Next slide. As a reminder, linking the data and abstracting medical records has an inherent time lag compared to what we receive from daily case report form data. So we know that we'll get a lot more complete data with our linkage, but it does take time depending on when in pregnancy the infection occurs. Next slide. So as of yesterday, we've been able to link over 3,000 COVID-19 cases in pregnancy from the CRF to a live birth or fetal death records. And these cases account for 0.4% of all cases in Tennessee. Here we can see the distribution of characteristics of women with COVID-19 in pregnancy who have had either a live birth or a fetal death. And this distribution geographically mirrors what we see in the general population. And we can see the breakdown here by both age and education as well. Next slide. So with the linkage up and running, we can start to examine some of our main questions of interest. So of our 3,060 cases of COVID-19 in pregnancy, there have been 4 maternal deaths in the state. 2 were COVID related and 2 were not. And about 3/4 of pregnant cases report symptoms and 9% were hospitalized. We also see 2% of all pregnant cases are admitted to the ICU. But it's really important to understand here that there's a lot of missing data. More than 80% were missing data for that ICU indicator. So it's really necessary to interpret that with caution. We're also seeing 60% of pregnant women infected in their 3rd trimester. And obviously with the time lag that we see from cases to delivery, we expect that distribution to continue to change. Next slide. Moving on to some infant outcomes of the 3,109 infants born to women with COVID-19 illness and pregnancy, there have been 19 fetal deaths and 11 infant deaths. Half of these fetal and infant deaths were delivered at 25 weeks gestation or earlier. There have also been 22 confirmed infant COVID-19 cases born to women infected in pregnancy. And of these 22 cases, 15 were diagnosed during follow-up and likely not due to that perinatal transmission. As you can see in the gray bar here, almost 3/4 of infants born to women with infection in pregnancy were not tested. And even when we look among just those women confirmed positive at delivery hospitalization, still 1 in 5 or 20% of those infants were not tested. Next slide. We can also look at birth outcomes of those with and without COVID infection in pregnancy by linking these data to our provisional birth file. We do see a higher rate of preterm birth in those born to women with COVID-19 in pregnancy compared to those without. We do not see differences in low birth weight, and we do see a higher proportion of NICU admissions among those infants born to women with COVID-19 in pregnancy. But it's important to interpret that cautiously, as anecdotally we've heard that infants are being placed in the NICU for infection prevention measures rather than needing a higher level of care. Next slide. As Dr. McDonald mentioned, we continue to see significant differences in COVID-19, and that applies to our pregnancy data as well. Both Hispanic and non-Hispanic Black women are disproportionately impacted. Next slide. We also see significant increases in the proportion of births to women with COVID-19 infection and pregnancy over 2020. So overall, births to women with COVID infection represent 3.1% of all births over the pandemic. But as we can see in December, 7.5% of all births were to women with COVID infection and pregnancy. Next slide. I'm going to briefly take a step back and contextualize how what we're seeing in Tennessee fits into a larger picture. Next slide. I'm going to mention 2 MMWRs that were released in November in which Tennessee contributed data to both. One focused on characteristics of symptomatic pregnant women with COVID-19 infection and found that severe illness and death were more likely in pregnant women than in non-pregnant women. And Dr. Hudak will go into more details, but I think the important part here is that the language on the CDC website changed with this study. And what I mean to say is that the CDC website now says, based on what we know at this time, pregnant people are at increased risk for severe illness from COVID-19 compared to non-pregnant women. Next slide. I'll briefly discuss this. This study focused on birth and infant outcomes following birth to a SARS-CoV-2 infected mother. And this study found higher estimates of preterm birth among infants born to women with COVID-19 infection and rare instances of infants testing positive at delivery. So really what we're seeing in our Tennessee data is reflected in the national data. Next slide. You can find more up-to-date data on the CDC website. And here you can see that 20 jurisdictions now report this type of surveillance data to the CDC. Next slide. We also make sure that we're not just looking at our population of those infected in pregnancy, but also our entire birth population. We additionally send our data to the National Center for Health Statistics so we can compare demographics and birth characteristics by infection status across all live births. And these data are updated every other month. Next slide. And another plug for some resources is, importantly, at the end of January, the CDC rolled out a one-stop shop toolkit for pregnant people and new parents for COVID-19. Next slide. Switching over to vaccinations, in December, ACOG recommended that COVID-19 vaccines should not be withheld from pregnant individuals who meet criteria for vaccination. Next slide. And a few weeks ago, the state vaccination plan was updated to include pregnant individuals in Phase 1C, which will officially open on this coming Monday, March 8th. And as Dr. Piercy mentioned in Tuesday's presentation, household members of pregnant individuals will also be eligible for vaccination in Phase 1C. This updated guidance will be formalized and released on Monday. Next slide. And earlier this week, ACIP held a COVID-19 vaccine safety update, which included analysis of what we've seen so far in vaccinations among more than 30,000 pregnant individuals. Of the 154 adverse events in pregnancy reported to the Vaccine Adverse Event Reporting System, 73% were non-pregnancy specific and 27% were pregnancy specific, including 29 reports of miscarriage. Next slide. It's important to always understand the background rates of adverse events when examining these safety data. For example, when we look at information from the VSafe pregnancy registry, while 15% of vaccinated pregnant women reported miscarriage, we see a background rate of miscarriage at 26%. So context matters. Next slide. The summary of the maternal vaccination safety data is listed here, with a key takeaway being that adverse events observed among pregnant women in VSafe did not indicate any safety problem. Next slide. I'm going to briefly discuss some next steps. Next slide. We're really focused at the Tennessee Department of Health on programmatic alignment across the department. We're working with colleagues to identify and prioritize the review of COVID-19 related pregnancy deaths. So back in September, we started incorporation of these cases in our review. On the right, you can see, based off initial reviews of COVID-19 related maternal deaths, we issued a quarterly notification through our partners at the Tennessee Hospital Association to communicate these emerging issues. One recommendation highlighted is that facilities are encouraged to provide increased postpartum follow-up with all COVID-19 positive patients, and there should be specific increased efforts to ensure additional communication for women with linguistic barriers. Next slide. We are also working with our colleagues to implement a COVID-19 supplement for our PRAM survey, which surveys postpartum women 2 to 6 months after delivery. Next slide. And as of last week, we officially started our longitudinal infant follow-up of our pregnancy cohort through 6 months of age. Next slide. And related to vaccines, we are initiating our tracking of vaccines in a few different women and maternal populations in the state. We're planning to participate in a vaccine effectiveness study, as well as work with our colleagues in the Health Disparities Task Force to address vaccine misinformation for pregnant women. Next slide. We continue to work on communication messages and pay close attention to equity in our outreach materials, including PSAs and infographics. Next slide. And finally, we're working on continuing communication with our key stakeholders, including this group, as well as those listed here, to continue to share our data and actions, as well as receive feedback. We're also currently working on publishing our findings to advance the research base, some of which are listed here. Next slide. Before I finish, I want to acknowledge what a team effort this has been. Lindsay Sizemore is my co-lead for this project. She's on the call, and we are supported by a wonderful team of epidemiologic and programmatic expertise. It's been a privilege to work on this project. Next slide. So thank you so much for your time, and we look forward to your questions.
Thank you so much. That was a great presentation from both of you. I think in the interest of time, we'll ask one quick question. Given the data that you presented on the loss of jobs and the unemployment rate, we would expect that children are going to be losing their health insurance at a higher rate than maybe before the pandemic. Are there things that the Department of Health is doing to address that or to help shore up access?
Yeah, a number of things. And we've been working closely with TennCare on this, both from TennCare and Cover Kids perspective. I think those on the phone are hopefully aware of the enrollment period for marketplace insurance, which was one of the first acts by the Biden administration was to reopen marketplace insurance. And so for those that may not be aware of that, please go on, check that out on the web. We've got links, as does TennCare, and the Tennessee Justice Center does as well, for that enrollment. And then our care coordination, both our presumptive eligibility in health departments as well as our CANT care coordination staff, is also available to assist families with enrollment in the case of unemployment or otherwise for any insurance plans that they may be eligible for.
Great. I think that's really helpful. What additional ways do you see this COVID-19 surveillance being used in the maternal child health population?
Lizzie, you want to take that one?
Oh man, we are. How long do we have? I mean, I think initiating infant longitudinal follow-up is going to be a real key piece here. We continue to learn more about what we can do. Initiating surveillance, again, tracking data. We're digging deeper into infant deaths, as Dr. McDonald mentioned before, into fetal deaths. So not only just the implications of COVID-19 specifically, but what are those downstream impacts to the maternal and child health population? So we're keeping an eye both specifically on what we're seeing in our cohort of infected pregnant women, but in general, what do we see in the entire maternal and child health population? So lots of things to continue to monitor.
Thank you so much, Dr. Harvey and Dr. McDonald. I know we have other questions, so we may send you some after the talk today. We appreciate you so much. Let me introduce our next poster presenter, Amanda Gary from UTK.
Hello, my name is Amanda Gary, and I'm a graduate research assistant at the University of Tennessee Graduate School of Medicine in the Department of OBGYN. I recently graduated in May of 2020 with my Bachelor's of Science in Kinesiology from the University of Tennessee, and I'm currently pursuing my Master's in Public Health there as well, from which I will graduate in May of 2022. Today, I'll be discussing my quality improvement project entitled Assessing Impact of SARS-CoV-2 on Access to Desired Sterilization During Delivery Hospitalization. The negative health implications of short interval and unintended pregnancies have been well described for both moms and babies. Sterilization during hospitalization has been deemed a non-elective procedure by reproductive health experts. During the SARS-CoV-2 or COVID-19 pandemic, healthcare systems were significantly impacted, especially at the beginning when PPE and other resources had to be allocated to prepare for the unknown. Some legislative figures even created a list of non-emergent procedures that should be postponed in an effort to preserve resources and decrease infections from spreading. In Tennessee, Governor Lee decided sterilization was one of these procedures, which may have impacted access until he was asked to reconsider this decision, which he ultimately did. Therefore, the goal of this project is to analyze the impact of COVID on access to desired sterilization during delivery admission. We defined a baseline period of January to June of 2019, followed by a pandemic period of January to September 2020, in a retrospective chart review of all women who stated that they desired sterilization upon admission in our electronic medical records. The data collected for this project included the number of women who desired sterilization on admission, the number of women who obtained desired sterilization prior to discharge, and the barrier that prevented desired sterilization when desired sterilization was not obtained. Barriers examined were grouped into one of 4 categories: missing a Medicaid consent, medical complication including obesity, changed contraceptive plan, and unknown barrier. During the baseline period, 28% of patients were unable to obtain their desired sterilization, while during the pandemic, 26% were unable. Though these rates of obtaining the procedure did not differ significantly, it is interesting to note that barriers did change in their reflective impact. During baseline period, missing or incomplete Medicaid consent and unknown barriers were the leading cause, while during the pandemic, medical complication was the leading cause. Additionally, more women changed their contraceptive plan during the pandemic, but reasons for this are still being analyzed. During the pandemic, contraceptive choice was still prioritized despite the additional challenges, indicating that offering contraception during a future pandemic or natural disaster is feasible as long as providers and legislative bodies understand the importance of continuing to offer these methods during crisis. Though our experience may differ from other institutions that may have followed Governor Lee's initial decision, we believe that our dedication to comprehensive contraceptive counseling and contraception initiative contributed to our results. We continue to educate new providers and nurses during the pandemic on the consequences of short interval pregnancies and the importance of comprehensive contraceptive counseling. We believe these efforts contributed to more patients obtaining desired sterilization than previous studies, such as Perinatal. In the future, we want to ensure continued access to desired sterilization during the pandemic. We also plan to assess barriers to desired sterilization prospectively to maintain data collection. Thank you for listening to my colleagues and I's findings on the impact of COVID on access to desired sterilization during delivery hospitalization.
Thank you, Amanda, for that presentation. As before, remember to click on the Engage button on the right-hand side, upper right-hand side of your screen, and then we'll go on to our next presentation. It is now my privilege to introduce Dr. Mark Hudak. Dr. Hudak is a neonatologist and the chairman of pediatrics at the University of Florida College of Medicine. He's also the immediate past chair of the AAP section on neonatal and perinatal medicine, and well known to our teams as the lead author of the seminal AAP guidance on NAS. He is now charged with the huge responsibility of coordinating the national AAP COVID database for moms and babies, and is here to give us an update. Dr. Hudak?
Good afternoon, everyone, and thank you, Anna, for your introduction. First, I have to congratulate Dr. McDonald and Dr. Harvey on their truly excellent presentation on how COVID-19 has affected women and infants in Tennessee. I think together they showed why Tennessee boasts one of the most forward-thinking and accomplished real-time evidence-based departments of health in the country. I'm grateful to the organizers of this meeting for the invitation to provide a bit more national focus on the consequences of SARS-CoV-2 infections in pregnant women and their infants. So, over the past year, we have all appreciated many ways in which this pandemic has profoundly affected individuals and institutions. Here's another way. How many of you feel, as I do, overwhelmed by an unprecedented blitz of information? Well, the numbers do back this up. By mid-February, just 1 year after we recognized that SARS-CoV-2 had entered the United States, there had already been 2,033 peer-reviewed publications related to perinatal SARS-CoV-2. And this is just a fraction of the entire published literature on this virus in general. So as a result, some of us who strive to stay current have constant PTSD. So I will try to provide some overall summary focus and not go too deeply into individual studies. There are so many of them. I'll concentrate on 3 areas. First, an amplification of what Dr. McDonald shared on SARS-CoV-2 and pregnancy. Second, I will provide a very high-level overview of perinatal transmission. And finally, I will share with you some preliminary data from the AAP National Perinatal COVID-19 Registry. This project has captured information on mother-infant dyads where the mother tested positive for SARS-CoV-2 in the window from 14 days before to 3 days after delivery. Okay, so during the first few months of the pandemic, certain urban areas were hard hit. Early on, Columbia University reported that 40% of mothers in their labor and delivery unit were testing positive. This raised great concern that pregnant women had a higher susceptibility to SARS-CoV-2 infection. As the dust has settled, however, 3 conclusions have become clearer. First, the likelihood that a pregnant woman would test positive for SARS tracked local community rates. You can see here that rates in 3 studies range from 0% at Cedars-Sinai in LA to 15.4% in 2 New York City hospitals. Among the New York City hospital patients, 88% of those testing positive reported no symptoms of infection. At Northwestern University in Chicago, 3.6% tested positive, and 44% of these were asymptomatic. Second, the likelihood of a positive test correlated with demographics that facilitated opportunistic viral spread. So, living in a densely populated household was a major factor in New York City. This obviously co-correlates with low income status, low property values, and unemployment. And third, all other factors being equal, the likelihood of a pregnant woman testing positive for SARS-CoV-2 was the same as for non-pregnant women of similar age. On the other hand, the data very clearly show that the severity of SARS-CoV-2 infection in pregnant women is much greater than in non-pregnant women of similar age. The CDC study that proved this was published just in November. They reported on 1.3 million women ages 15 to 44 who had a positive SARS-CoV-2 test. The data revealed the pregnancy status of 30% or 410,000 women, and as one would expect, about 6% of these women were pregnant. The investigators were able to adjust for some underlying medical conditions, age, and race ethnicity, and determine the adjusted relative risk of a number of indicators that attested to greater disease severity among pregnant women. For instance, you can see here the risk of ICU admission, the use of invasive ventilation, ECMO utilization, and mortality were all significantly higher in pregnant women. Notably, this report confirmed prior observations from single or multiple centers that minority populations were disproportionately targeted by the disease. Black women represented 14% of this cohort, but experienced 37% of all deaths and 27% of deaths among pregnant women. And the highest adjusted relative risk for death occurred in the Hispanic and Latina women population. Okay, another recent report analyzed another population using the Premier Healthcare Database, which is all payer information for 20% of U.S. hospitalizations. This study found that among 406,000 women who gave birth, 6,000 or 1.6% had a diagnosis of SARS-CoV-2 infection. Compared to non-pregnant women of similar ages, they found significantly higher adjusted odds ratios for a host of problems, including ICU admission, invasive ventilation, and death, morbidities such as myocardial infarction, venous thromboembolism, or any thrombotic event, and then pregnancy-related morbidities, including preeclampsia, HELLP syndrome, preterm labor, and preterm birth. Now, whether COVID-19 directly increases the rate of stillbirth remains unclear. While one UK study did not find a significant increased risk of stillbirth in COVID-19 infected mothers, other studies have reported an increased rate of stillbirths in the general population during the pandemic. Although none of the stillbirths in one UK study occurred in women known to have SARS-CoV-2 infection, universal screening has demonstrated that a large percentage of pregnant women with SARS-CoV-2 infection are asymptomatic. Alternatively, the increased numbers of stillbirths observed in some areas during the pandemic could be due to indirect effects that led to voluntarily reduced access to the healthcare system or to decreases in the availability of routine obstetrical services. So, does maternal SARS increase infant mortality? This is a complex question. There may be a direct effect mediated by an increase in preterm birth, which most studies have found. There may be indirect effects mediated by decreased access to care. and these may be counterbalanced by a decreased rate of preterm birth in the entire population. We will just have to wait to see what might be the net effect. Mothers, like others, can have prolonged recovery. The UCSF Priority Registry reported a median time of symptom resolution of 37 days, and 25% of women still had symptoms 8 weeks after delivery. It is not known whether postpartum women have recoveries that are more extended than a comparable group of non-pregnant infected women. Finally, systemic steroid therapy is now a mainstay of the treatment of SARS-CoV-2. But in pregnant mothers, the recommended course might be harmful to the fetus. It is possible to transition after 2 days of betamethasone to an equivalent dose of methylprednisolone, which does not cross the placenta. And then lastly, possible long-term sequelae of COVID-19, such as accelerated cognitive decline and chronic respiratory and cardiac dysfunction, are not yet defined in this population. Possible routes of perinatal transmission include transplacental or in utero, intrapartum transmission by blood or vaginal secretions, via breast milk, and postnatally via respiratory droplets. However, important to point out that no one yet has recovered replicable virus in vaginal secretions or breast milk. A WHO team of experts has just published standards in February. In the usual clinical non-research setting, the diagnostic and testing requirements to confirm an in utero diagnosis are very onerous. We also know that infants reported from China who had IgM in cord blood, there were weaknesses in the assay, and those infants had no clinical signs of disease. In other reports, postnatal contamination probably accounts for the findings. Placental pathology does not always equate to fetal disease. Recently, Flannery et al. In the group from CHOP reported on 1,471 maternal newborn dyads where they analyzed paired maternal and cord blood. They found IgG or IgM in 83 of the women and 72 of the babies born to those 83 women, but no IgM. And similarly, Edlow et al. Recently reported that only 1 in 77 specimens of cord blood had a IgM positive test. So bottom line, although there are some good case reports out there that strongly suggest perinatal transmission, I think we can conclude that if it does occur, it is extremely uncommon. All right, the UK obstetrical surveillance system includes 194 delivery hospitals. Initial report from this group showed that 12 of 265 infants born to mothers with positive tests were themselves positive. That's 5%. Chris Gale and others reported a 2-month interval. 66 positive infants were admitted, 0 to 28 days of age with a positive test. There's 1 death that was not due to SARS. The study was written in a confusing way, but it appears that there were no confirmed cases of perinatal transmission in that study. And finally, Dr. Sanchez Luna with the Spanish registry reported on 503 infants born to 497 mothers with positive SARS testing. The preterm rate in that group was 15.7% versus the usual 6.5% national rate. 20% of those infants had mild signs of disease, and 3% had a first positive test. So now to the registry. You will recall that there was vigorous discussion about best perinatal practice guidelines. AAP posted its initial management in April. AAP did recognize the need for better guidance, so this was always intended to be a dynamic document. And in fact, it has been modified a few times with just another modification posted. And there's no doubt that the initial guidance did engender a lot of passionate discussion across the country and across the oceans. So to address the need for data, which really will drive some of these guidelines, the evidence, our section establishes registry to acquire geographically representative information on perinatal COVID-19. The section committed to providing these data in near real time to the entire community. The section took the initiative to develop this national registry with the following purposes. First, to determine the risk that newborn infants may acquire COVID-19 by vertical or early horizontal transmission mechanisms. This question is morphed to what is the likelihood that an infant will test positive at different times during the hospital stay. Second, to assess the relative effectiveness of different infection control practices on the rate of positive infant testing in the hospital. Third, to assess the safety of breastfeeding. And fourth, to describe the spectrum of illness in newborns. Our current registry data will not answer this last question fully. We do plan to expand our effort to include outpatient or at least phone follow-up through the period of time during which the mother or other family members or household residents had infectious COVID-19 disease. We obtained IRB approval in late March last year, and over the first month or two, we all learned a lot more about this disease, and in particular, the vexing limitations of PCR testing. We discovered that PCR tests could remain positive for months, well after an individual became non-infectious. So we added a resolved arm to the registry with the objective to determine whether maternal infection in early gestation caused primary or secondary adverse events in the fetus. Now, as of yesterday, we have 297 hospitals in 45 states and the Washington, D.C. and Puerto Rico that account for 1/5 of all U.S. births. I'm really pleased that there are 5 Tennessee hospitals participating, including the Erlanger Health System in Chattanooga, Vanderbilt in Nashville, Jackson-Madison County General Hospital in Jackson, University of Texas Medical Center in Knoxville, and the Regional One Health Route Center for Women and Infants in Memphis. So today we crossed 7,900 dyads in the active registry and nearly 1,200 dyads in the resolved arm. And I'll be reporting on demographic data and analytical data on the 7,672 dyads entered through February of 2025. Okay. The great majority of mothers who test positive close to delivery are asymptomatic, although I do use that term loosely because it may be difficult to distinguish OB and labor symptoms from symptoms due to COVID-19. About 1/4 of pregnant women admit to some symptoms possibly related when they present. And 1 in 30 mothers required hospitalization specifically for treatment of severe infection. This disease in our study has affected minority populations in the U.S. very disproportionately. This is also true among pregnant women. Note the disproportionate representation of Hispanic pregnant women. With respect to infant care protocols, the majority of infants now room in with mother. About 1 in 4 infants has been admitted to a NICU, and over 70% of infants have received breast milk. About 83% of infants had at least one PCR test done during their birth hospitalization. Only 2.2% of tested infants have 1 or more positive tests. Most babies, okay. There we go. Most babies born to mothers with positive testing are asymptomatic in the hospital and go home. About 11% were noted to have respiratory distress, but none of these babies was thought to have COVID-19. 1% of the babies died, and these include many stillbirths, but none due to COVID. And about 1% were transferred to other hospitals, and we don't have follow-up on these. Among all infants, 6,354 had at least one test performed, and of these, only 129 infants had positive tests in the hospital. In 13 cases, an infant had one positive test followed by 1 or more negative tests. Could these have been false positives, or could they represent transient colonization? 33 infants had a first test that was negative followed by 1 or more subsequent positives. Most of these are likely to be infections. 83 infants had 1 or more positive tests and no negative tests. Again, among the infants with a single positive test, these could have been false positives or colonizations. Even though AAP guidance advises that each infant have at least 2 tests before discharge, not all centers could always adhere to this. So it is likely that some infants who had a single negative test on day 0 or day 1 might have tested positive subsequently. To restate, we found a low rate of positive testing at 2.2%. We hypothesized that infants born to mothers who tested positive more than a week before delivery would be at lowest risk of having positive tests. This table serves to validate that hypothesis. Infants born to mothers who tested positive for the first time closer to delivery had a higher risk, although the absolute risk was still low. To emphasize, these data provide a minimum estimate of the percentage of infants who might test positive because of different testing practices at the center. Then we examined whether infants born to mothers who were asymptomatic had a lower rate of positive testing. And in fact, the trend is that they did have a slightly lower absolute risk, but certainly not in a clinically meaningful way. Finally, infants born to mothers who had symptoms of COVID-19 on hospital admission were slightly more likely to have positive tests, with rates as high as 4%. We were also interested in determining whether there were any differences in demographics between infants who tested positive and those who tested negative. Among infants who did test positive, more mothers were sick with COVID-19, and this contributed to the greater length of stay. Infants who did test positive had a slightly lower birth weight and gestational age. It will be intriguing to see if this holds up. Does this observation mean that transplacental disease may result in greater likelihood of preterm birth, or that mothers who are ill with COVID-19 are more likely to deliver prematurely? Clearly, these infants had longer length of stay, but it is likely that this correlates with a greater degree of prematurity. Signs of possible COVID-19 infection were seen more frequently in infants who tested positive, but again, this could represent an effect of greater prematurity or could represent ascertainment bias. We were unable to detect any differences in the rate of positive testing related to whether infants were separated or they roomed in with their mothers. The rates are 2.1% among those separated and 2.2% among infants who roomed in. What we did find, however, was that the likelihood a mother was sick with COVID was nearly double among those infants who were separated. But this probably only reflects that these mothers were just not physically able to care for their infants, or that their illness may have been a determining factor in the assessment of risk in shared decision-making. We have begun to publish some results from the registry. We partnered with our UK colleagues to compare our experiences through August. This report is accepted and is available as a pre-publication. We both found an increase in preterm births among our exposed newborn cohorts compared to recent historical nationwide figures. Our distributions were fairly similar. Okay. Next slide. Thank you. Okay. Comparing the frequency of preterm live births in our registry cohort to U.S. national 2019 figures, most of the increase in numbers are among the late preterm infants, gestational ages 34 to 36 weeks. There is a smaller absolute increase, but probably a more impactful increase in the frequency of preterm live births from 22 to 33 weeks. In 2019, the U.S. rate of preterm births is 10.23%. In our registry, it is 15.38%. Within the registry, we have rather robust descriptive information on the maternal and fetal indications for accelerated deliveries. Compared to 2019, we can estimate that our cohort includes 392 excess preterm births. Parsing through the indications data, about 170 preterm infants were delivered by induction or C-section due to concerns about worsening COVID-19 disease and possible or actual effects on the mother or fetus. This still leaves us with a residual of 222, or 57% of these excess births, for which there is not an obvious explanation. Could there be secondary effects of SARS-CoV-2 maternal infection? For instance, does infection itself stimulate preterm labor? Or might it be more likely to cause fetal hypoxia, leading to an increase in non-spontaneous births? One of the analyses we have not yet done is to track the prematurity rate and the reasons for non-spontaneous delivery over time. It is possible that preterm birth may decline over time once physicians have a better understanding of the natural history and can better manage infection with the goal of safely prolonging pregnancy. One last tidbit among many that I could share. We looked both in the UK and the US registries for any effect of infection on fetal growth. This plot shows percentiles of birth weight by gestational age. There was not a shift in the Gaussian distribution, as you can see. The percentage of babies born SGA, less than the 10th percentile, was also not increased. We will repeat this analysis for infants entered in the resolved arm of the registry. So in summary, what have we learned from our collective experiences? First, we presume now that many women enrolled in this active arm were not infectious. They may have resolved their infection well before coming in for delivery. Second, infants are more likely to test positive but still have a very low risk the closer the first positive maternal test is to the day of delivery. Third, the lowest rates of positive testing occur among infants whose mothers have an initial positive test or onset of illness greater than 1 week in the week before delivery. Lowest rates greater than 1 week. Transfer of maternal antibody may also be protective. Fourth, there's no difference in the overall rate of testing between infants who are separated from those who room in. And finally, to reemphasize, we do need more information to determine whether the increase in preterm births in SARS-positive mothers is real, and if so, what are the causes? So some closing thoughts. So this pandemic has made it ever so clear that new knowledge develops rapidly. We lag behind other countries such as the UK in this regard. At the beginning, there was a lot of emotion about how best to manage mothers and babies. Both sides had valid but opposing points and different belief structures, but both sides advocated for mothers and infants. So far, our outcomes are laboratory tests of uncertain meaning. We do need large population numbers. We do need outpatient follow-up. Preliminary data from the Massachusetts Collaborative and other studies are reassuring, but we need to nail that down. And finally, I must applaud the incredible generosity, the volunteerism and teamwork among our large neonatal community that became astonishingly evident during this effort. Caregivers and hospitals really stepped up to the plate to make this registry possible. We really are blessed to work with as part of a fantastic neonatal community. So thanks very much.
Thank you so much for that talk, Dr. Hudak. We do have time for questions. If you guys want to chat those in, we'll try to get to them. I'm going to ask the first one. Have there been any reports of mothers with MISA come through the registry? And do you have any thoughts that pregnancy immunology may be protective against that?
Oh, wow. Okay. No, we don't have any good information about MISA. We have, it'd be hard to tease that out of the information we asked. When we started the registry, we didn't even know about MIS. So we can go back and try to sort of figure that out. The second question was whether or not pregnancy protects against that, you said?
Yes.
That's a great question. I can't tell you. We're going to go back and we're going to look at it. We've had 13 maternal deaths in this cohort due to COVID-19. We've had 3 deaths that were supposedly unrelated. But we've had 37 mothers who've been transferred for higher level of care because of COVID-19 disease. And one of the things we want to do is see if we can get some more information on those outcomes. We may have underestimated the maternal mortality. Each maternal mortality in this cohort is an excess mortality, right? Wouldn't have occurred under normal circumstances. And if you look at the CDC website, and I've got it sort of pulled up on my other screen here, they're up to 80 maternal deaths out of 73,000 cases. So that is basically, 110 per 100,000, which is 7 times the normal national rate. And our cohort basically shows the same thing. We've got 13 in 7,000, which works out to be 170 in 100,000. So it is no doubt a big impact on maternal mortality.
Those cases one by one is going to be incredibly important. I'm glad you're doing that work. Another hard question, can you speculate on the variants and if there's going to be any protection of maternal antibodies for the baby?
I think 2 things about the variants. That's one of the reasons where investigators have asked to keep the registry open going forward, is because of really the unknown effect on these variants on perinatal disease. It's certainly conceivable that a much more highly transmissible virus might actually cause significant disease in babies. We'll have to see. I think, though, that if mothers make antibody against these variants, it will be protective for the babies, both as transferred, across the placenta and as also delivered through breast milk. And the recent study that just came out that demonstrated, in fact, there is protective antibody, in breast milk. So That's very important for mothers to do.
Breast milk is always the best thing, right?
You bet.
All right, one more question and then we'll move on. Please clarify if there was an increased level of preterm births in mothers who were COVID positive and African American or Hispanic. So I think they specifically are asking if the number of preterm
higher
would be teased
Blacks and
out.
Hispanics.
Yes.
I have to confess, I can't recall. I will
Okay.
I will look at that tonight, and I will text that in. Okay.
That would be amazing. Thank you so much. All right, Dr. Hudak, we appreciate it. We are so admiring the work that you're doing with this and appreciate your hard work on this registry. I'm going to turn this meeting back over to Dr. Young so she can introduce our next speakers.
Hello again. It gives me great pleasure to introduce to you Drs. Danielle Tate and Dr. Connie Graves. Both Drs. Tate and Graves are maternal fetal medicine specialists and also serve on our TIPQC oversight board, as well as being state project leaders, so we keep them very busy. Today, they're going to share about the Tennessee COVID Mom Study.
Thank you, Dr. Young. For just the next few minutes, Dr. Graves and I are just going to give you guys a few updates on state-specific COVID data that we've obtained over this past year. I know we've heard about national and overall state data, so we will just present from our organizations what we found over the past year. Regional One Health, where I reside, we did our first study looking at the correlation between fetal demise and the pandemic. It was a retrospective cohort study that looked at patients in two cohort groups. Our first group was the COVID cohort group that delivered between March 1st of 2020 and July 31st of 2020. And our pre-COVID cohort group delivered between March 1st, 2019 and July 31st, 2019. All patients in the COVID cohort group did undergo mandatory COVID testing at the time of their admission of diagnosis. Of those in the cohort group with COVID, we found that only one of those 26 patients within IUFD actually tested positive for COVID-19. We had a rate of about 3.8%. When looking at rates of IUFDs between the two cohorts, we found that those in the cohort with COVID or during COVID were found to have significantly higher numbers of IUFD, at times tripling. Overall, the rate between the two groups, 8 per 1,000 births in the pre-COVID group and 23 per 1,000 in the COVID group. When we further divided these groups into early and late IUFD rates, you can see that still significantly higher IUFD rates in the COVID cohort group. And we define late as greater than 28 weeks of gestation. Breaking down the groups in comparison per month throughout the time frame, you can see in monthly comparison in the pre-COVID group, far less number or rate of IUFD when compared to the COVID cohort group. That COVID cohort group at times reaching double or triple the amount of IUFDs that we had seen in the previous year. When digging deeper into the demographics, we saw that overall the two groups had similar comparisons, but when we zoned in on adequate prenatal care. We found that those in the COVID cohort group were definitely ones that were more likely to have inadequate prenatal care. And inadequate we defined as less than 4 prenatal visits during the time of their pregnancy. So what we found in conclusion was that there was an increase of IUFD rates in our population during the pandemic, but no direct correlation with fetal demise and COVID-19 infection itself. But our findings do suggest that the effect of a global pandemic definitely extends beyond the obvious negative health effects that we see when we talk about pregnancy-related outcomes. The second study I'm going to highlight actually comes from our neonatology group, specifically Dr. Lamba and his team. Their study set out to report on hospital practices and neonatal outcomes in those neonates susceptible to COVID-19 due to mothers' COVID-19 positive status. This study was actually a prospective observational study that looked at in-hospital and post-admission outcomes up to 8 weeks post-discharge for the neonates. Of that, they found that there was a total of 62 mothers that tested positive for COVID-19, and the time frame used was April 1st to December 31st, so right in the very high times of COVID. Of those, only 81% of mothers were asymptomatic, so the majority were actually tested positive due to routine screening per our protocol. 97% of the neonates tested were actually tested negative, with only 2 positive, and those were at 48 hours of life. The mean gestational age of delivery for these pregnancies were 37.3 weeks, and the mean birth weight, 2,991 grams. Of those, about 75% of the infants did not require any respiratory support. A few did, one actually requiring ECMO, but that was due to meconium aspiration syndrome. After discharge, they were able to follow the patients up to 8 weeks of life, and they found that during that follow-up, no newborns were reported with any symptomatic or asymptomatic infections, and they checked at 1, 2, 4, and 8 weeks post-delivery. So in conclusion, they found that the risk of perinatal transmission was appropriate, and it was actually low due to the appropriate means that they took on, and the group did take on very early in the pandemic, following all the guidelines and initially isolating and then doing safe rooming in with mothers and babies. And what they found that there was no infant as well that went home with a delayed infection or delayed symptoms related to an infection.
I'm now going to present you data from our hospital at St. Thomas Midtown. This data is from our resident clinic. Next slide. We're going to be looking at COVID-19 in an outpatient obstetrical population. And more importantly, we're going to be presenting some novel data about the use of telehealth and being able to keep up with this population. As I begin this lecture, I must highly apologize. My resident who helped me collect this data is here, and I'm having an emergency in the clinic, and he's going to take over the next slide, and I will be right back. Okay.
Hi, thank you. I'm John Anderson. I'm one of the second-year residents here at the UT Nashville program, and our residency program. This is our outpatient clinic that we've collected this data from. So we can advance to the next slide. So we saw a total of 88 patients from our UT clinic, and additional affiliated outpatient clinics here in Nashville were seen by telehealth visits as of February 10th of this year. 4 patients are currently pregnant and asymptomatic and being followed by telehealth. We had 18 patients who are now COVID recovered and are also pregnant, and we've had a total of 66 patients who are now COVID recovered and postpartum. 12 patients, 3 pregnant and 9 postpartum, met criteria for enrollment in telehealth visits, but did not follow up by telehealth and chose to follow up after they were recovered in their respective other outpatient clinics. Some of these patients also did not alert the UT clinic to their positive diagnosis until they were after or through their recovered period and did not need telehealth anymore. Just gonna go over?
Yeah.
Okay.
Go. Continue.
Okay. And UT residents and faculty were involved in the care of about 20 additional COVID positive inpatients who followed up with other outpatient clinics after they were discharged from the hospital. Next slide. Patients of the UT clinic or our affiliated clinics were designated following any positive tests during routine prenatal care or during any inpatient admission for COVID symptoms or otherwise. We were doing routine COVID testing of all of our inpatients on the resident service really since the start of COVID last March. Patients entered into the telehealth program were scheduled for virtual visits on either Monday or Thursday afternoons. These visits were primarily conducted by Dr. Ann Williford, who is one of our UT faculty members. Next slide, please. Patients with a positive COVID test who remained symptomatic were followed by virtual visits for at least 10 days following their positive test. The most recent CDC guidelines were used to determine when patients could be transitioned back from virtual visits back to their routine in-office visits. In general, patients were considered candidates to return to in-person visits when they were greater than 10 days from their positive tests and without fever or symptoms for 72 hours. The primary focus during these telehealth visits was to screen patients for symptoms of severe COVID disease, educate patients about when to seek emergency care for COVID symptoms, assess routine OB concerns, and to help patients secure a pulse ox for at-home monitoring of O2 sats. Okay, next slide.
Okay, next slide. Once the patients were considered eligible to leave quarantine, they were initially scheduled for their first visit with Dr. Williford on Monday or Thursday in the afternoon. We also provided blood pressure cuffs for these patients so they could have care at home. COVID patients returned to in-person visits, and they were kept these in time slots, and they separated them from the rest of our patient population. Once the patients were remote from diagnosis, they transitioned back to routine care, and appointments were scheduled normally. Next slide. No maternal or fetal neonatal deaths occurred in our patient population. 3 patients without respiratory symptoms were admitted with threatened preterm labor and did not deliver preterm. 1 COVID positive patient without respiratory symptoms was admitted with preterm labor and did deliver preterm. 13 patients required inpatient admission for severe COVID. 4 required ICU admission. 3 required mechanical ventilation. Of the 3 that required mechanical ventilation, all of them were extubated and either delivered during the time that they were in the ICU. One of them actually required mechanical ventilation at 22 weeks. She was extubated, sent home, and delivered at term. Next slide. A significant portion of our patients in the clinic are non-English speaking, and so that became a challenge to us as the language barrier is frequently an issue. So we use virtual visit software that was used in our clinic, of course, was not compatible with our interpreter program, and so a portion of these visits had to be conducted by phone calls. And as someone who has done telehealth, a lot of times what we have to do is actually hold our cell phone and the interpreter up to the telehealth screen and then do the interpretation and kind of go back and forth, because we have not found a telehealth platform that has been suitable for translation. Obtaining lab work and other antenatal testing during the quarantine was difficult. During the warmer months, the patients were able to drive through for lab draws, but this was not accomplished during the winter months. And often we share these patients in the high-risk clinic here. And so what we would often notice is patients would come in and just not tell us they were COVID positive, which was another challenge. And so then we would have exposures of our patient population. Next slide. Patients were offered a pulse ox during their infectious period, but initially struggled with physically getting them. And then the clinic began to deliver these pulse ox to the patients through the drive-through center. They continued to stay up to date on the changing guidelines when patients were suitable to return for inpatient visits and communicate changes to upper management to allow prompt adjustment in the clinical policy, which again, I think was a very difficult thing for us to do, especially in early COVID. Also communicating changes in the clinic and hospital policy to the residency program and the clinic staff at large, because often, especially in this patient population, and I'm sure that Dr. Anderson will agree, we had a lot of trouble because of the mother-baby policies and the changing with that as well, given the fact that many of these patients do not speak English. Next slide. COVID during pregnancy can be particularly challenging. Data suggests that there's increased mortality around these patients and morbidity, and telehealth may help bridge this gap for the needed care in this population.
Oh, sorry. Thank you, Connie and Danielle. For our final session presentation, it gives me great honor to introduce KK Dixon. KK is the national spokesperson for the Preeclampsia Foundation. She's a mom to 1-year-old Kari J and credits her partner, NBA standout Ja Morant, in saving her life, along with the care of her team at Regional One Health. KK is determined to share her story in hopes that other women, particularly those who are young and women of color, do not experience the same terrifying ordeal that she did. I also had the pleasure of talking with her on our TIPQC podcast, so I hope you all check that out as well. But please join me right now in welcoming KK.
Hi, everyone. My name is Kadra Dixon. I'm going to be a spokesperson for the Preeclampsia Foundation today. A little bit of background on me is I was born and raised in Arkansas, born in Antoine, Arkansas, raised in Bentonville, Arkansas, and finished off my high school career in Little Rock, Arkansas. So Arkansas girl at heart. I grew up an athlete. I played volleyball and basketball. After high school, I moved to Tennessee. I'm currently attending Middle Tennessee State University. I graduate this May with my bachelor's in health and human performance. So I'm super excited about that. And I am a mom to my best friend, Kari J. And a little bit of background on how I got involved with TIPQC. So I was honored to be on the Healthy Mom, Healthy Baby podcast with the TIPQC Maternal Medical Director. Her name is Jessica Young, and this was published December 21st. And I'm on episode 8. It is titled A Mom's Story with KK Dixon. And what we talk about on there, I'll be talking about today. So just to get into that, I've been working with the Preeclampsia Foundation because preeclampsia affected my pregnancy. So it really gave me the push to want to work with them and educate others on it. So this slide is a little bit about what preeclampsia is. So as you can see, it is a serious disease related to high blood pressure. It can happen to any pregnant woman during the second half of her pregnancy and up to 6 weeks after her delivery. So the risks are seizures, stroke, organ damage, and death. And that's to the mother, and for the baby, premature birth and death as well. So, and then an important part of preeclampsia, like recognizing it, is recognizing the signs. So there's some of the signs of preeclampsia right there that you guys can look at while I'm talking. So for me, I didn't know what preeclampsia was at all leading up to my pregnancy. I was having, a normal pregnancy. I was 19 years old, young, healthy, I had cravings, all the, basic things of pregnancy. And towards about my 31 week mark, my vision started changing. I started rapidly gaining weight. And, I just was trying to push through it and be strong and, not complain, because like as a mother, you want to be strong. So I was just pushing through it. And then one night, it was about 2 or 3 a.m. I was in bed and started suffering from seizures. So Kari's dad had to, call the ambulance. So it's a very traumatic birth experience for us, especially him, just being young parents, not knowing what's going on, like pregnant and having seizures, unresponsive, and having to, rush, have an emergency C-section. So a lot was going on. And the funny thing is with that, we had looked up on Google that same night. We was like vision changes in pregnancy. And jokingly, her dad was like, it means you're about to have the baby. And so we just kind of like laughed it off and was like, okay, well, we'll call the doctor and go see the doctor tomorrow. But we didn't even make it to that because I started having seizures through the night. So even just bringing awareness to preeclampsia and, like not taking stuff like this as a joke and being more educated on it. So we know that it is a serious topic and it's not, just, oh, brush it off, we'll, go see in the morning. So at the bottom, you can see is what you should do. Call your doctor or midwife right away. And finding preeclampsia is early because I was signs and symptoms, like looking back now that I know what they are, I was suffering from these signs and symptoms for at least a week or so. So just knowing that, we could have had a completely different outcome. And so here are some pictures. On the left, this was right after I had the emergency C-section. So I did have her at 31 weeks. And then after that, so this top picture on the right, this was her in the NICU. So she was in the NICU for about 6 weeks. And so even that as a mom experiencing, you have to go home without your baby. So I was like, I never want any mom to have to go through this if it's preventable. So I was like, when I bounced back and, started feeling better, I was like, what can I do? Where can I get involved to make a change? So, I mean, even if I help just one mom, catch, the signs of preeclampsia, I'll feel good. And so then this bottom picture is one of her first nights home. So super, super happy. And so I started working, reached out to the Preeclampsia Foundation and started working with them. And one of the first things that we did was the Promise Walk. And what the Promise Walk is so since 2005, the Promise Walk for Preeclampsia is a fundraiser and raising awareness. So Black women are 3 to 4 times more likely to die from pregnancy complications than white women, according to the CDC. So that really stirred me the wrong way because I was like, that's significant numbers. And so it just really hit home because my family, I come from a background, I have a Black and white family. So that just hits home because so much of my family could be affected by this and is affected by this, and my daughter. So I was like, one day I don't want my daughter to have to risk, be risking her life, bringing such a beautiful gift into the world. And so these, this slide, these are some of the signs and symptoms of preeclampsia that you can just look over while I'm talking. But in my part that I wanted to play, my role that I wanted to play with this foundation was, making more people aware of these disparities in healthcare and how to, bridge the gap between the patient and the provider and, become, more comfortable, sharing our feelings and thoughts, when we are pregnant. So one more thing that I wanted to share with you was a little, this is a short paragraph from Dr. Anna Langer. She's the director of the Women in Health Initiative at the Harvard Tate School of Public Health in Boston. So she was regarding how Black women are 3 to 4 times more likely to die from pregnancy complications. She was saying that it's basically a public health and human rights emergency because it's been estimated that a significant portion of these deaths could be prevented. And the reasons behind the racial disparities are many and complex, lack of access, and poor quality of care are leading factors, particularly among women at lower socioeconomic levels. But she said there's a bigger problem. Basically, Black women are undervalued. They are not monitored as carefully as white women are. When they do present with symptoms, they are often dismissed. So that was really intriguing to me, just how these racial disparities still exist, and we are still, as a nation, coming further and further each year. So I just want to be a part of that and, speed that process up, help that process, because all women should know like what preeclampsia is, what the signs are. And so like she was saying, the lack of resources, the lack of understanding. And that's why the Preeclampsia Foundation, like their main mission is getting more, resources and patient education and having people understand why that is so important. And so here is a little slide of my daughter currently, just to show that, just to end off on a good, fun note. She is doing amazing now. We had a rough journey at the start, but, so thankful for everyone, the Preeclampsia Foundation, just being so supportive. And, one day I hope that she will see all of this and, be ready to help more people as well.
Thank you so much, KK, and to all of our speakers today, and to our colleagues at Regional 1 that cared for KK and her daughter. Be sure and listen to KK on the TIPQC podcast, as she mentioned, if you're interested in hearing that. And you can also sign up for future podcasts if you're interested. We are going to take a 15-minute break today, and we will return at 3 Central, 4 Eastern Time for the workshop of your choice. Click on the file below. And then that will be followed by the closing ceremonies at 4:30 Central Time. And I know you won't want to miss that, because you'll hear the results of our project voting, as well as the recognition of our award winners. Again, take a step outside, as Laura encouraged us today. Hopefully you don't have to check your voicemails, and you can have a good, little bit more than a 15-minute break. We'll see you in the workshops. Thanks.
It's a beautiful afternoon in Middle Tennessee. I hope it is where you are too. Thanks to all of you for joining the last 3 days of learning, conversation, and inspiration. My name is Susan Guttentag, and it's been my privilege to serve the last 5 years as the principal investigator for TIPQC. I have never been more impressed by our annual meeting than I have been for this year, in the midst of a pandemic. It's a testament to your dedication to our mission that we've been able to continue our important work on behalf of Tennessee mothers and babies. TIPQC began a process of rotating medical directors 4 years ago, with each serving a staggered 2-year term. It's always bittersweet to say goodbye to a TIPQC medical director, and this year is no exception. Anna Murad has served TIPQC for the last 2 years as the infant medical director. Dr. Murad has been instrumental in many projects TIPQC has conducted over the years. She was a state leader for the breastfeeding project, as well as the preterm infant project that optimized the care of babies born at 35 to 36 weeks of gestation. As the current medical director, Anna has overseen the Opioid Exposed Newborn Project, as well as the Safe to Sleep Project. She brought her expertise and experience as the president of the Tennessee chapter of the American Academy of Pediatrics. She has served as our first general pediatrician in the infant medical director role, setting the stage for more to come. Thank you, Anna, for all that you've done for TIPQC.
Anna, thank you so much for all of the time and effort that you dedicated to TIPQC as the infant medical director. we'll miss you in TIPQC, but I'm sure that we're going to see you again. And as a token of this, of our appreciation, this we hope will be a memorable gift.
Thank you, Susan. Let's see. I suspect I know what this may be. It's a perfect likeness. The Anna bubble. Oh, you gotta love a bobblehead. So thank you so much. I've enjoyed every bit of leading TIPQC for the infant medical director these past 2 years, and have really enjoyed my time. I'm not going very far. I'll still be on our local teams. Still hope to see you all. But thank you so much for this opportunity, and I've really enjoyed every minute.
As one door closes, another opens. It's now my pleasure to introduce and announce our next TIPQC Infant Medical Director, Dr. Scott Guthrie. Tennessee has had wonderful leaders across our state, and so we're so grateful when one steps up to become one of our medical directors. Dr. Guthrie is a neonatologist at Jackson Madison County General Hospital. He brings his years of clinical experience and QI expertise, as well as his enthusiasm for simulation training that will work well in our next TIPQC project. Thank you, Scott. We all look forward to capitalizing on your expertise over the next 2 years. And now it's with great admiration that I turn the program over to our 2 current medical directors, Dr. Jessica Young and Anna Murad, for their reports on your accomplishments from the past year.
Thank you so much, Dr. Gutentag. I would like to take this opportunity to give a virtual round of applause to Brenda Barker and all the TIPQC staff, Amanda Nally, Steve Compton, Bonnie Miller, Terry Scott, and Patty Scott, who really make all this happen. Not just the annual meeting, which requires a massive amount of work, but also the day in, day out work of keeping a statewide quality improvement organization moving forward and improving perinatal care for mothers and infants throughout the state of Tennessee. We have completed wave 1 of the opioid use disorder and opioid exposed newborn project, and our teams have put tremendous effort and work to make a difference for this marginalized population. We had 13 teams involved in the OUD and pregnancy project. We also created a toolkit, an implementation roadmap. We looked at over 3,178 charts. We also have data on over 1,100 women. To do this project, we created a toolkit. We created a toolkit that merged both the opioid use disorder and opioid exposed newborn project into one toolkit. We created a roadmap to implement all these changes. And through implementation of the AIM maternal safety bundle on opioid use disorder, we were able to make some significant strides. We met monthly with our teams in huddles. We did quarterly learning sessions, and you all know how much data collection you did, which is amazing. What we saw was a 60% increase in medication-assisted treatment, which is life-saving for women with substance use disorder. We also saw that 70% of opioid-exposed newborns were discharged home to biological mother. This means that we have made a difference for moms prenatally in order to make that happen. Next, I'm going to focus on some of the potentially better practices that we've focused on in this project and in the improvements that have been made. Next slide. First up is screening. For substance use disorder screening, we have documented improvements from 85 to 98%. This means our teams are recognizing that recognition of substance use disorder in pregnancy is critical. Next, we'll also talk about overdose prevention, and we'll talk about opioid use disorder treatment. Moving on to screening, this is looking at any substance use disorder screening that was documented for our teams. And you can see that we made an improvement up to 98% in the last 4 months of 2020. And so this means we are screening more women as they enter prenatal care and particularly as they come to labor and delivery. Next slide, please. As far as using a validated screening tool, we've made improvements with an increase statewide from 23 to 57%. We would like to see this number higher and think that with wave 2 of this project, we can get closer to 95%, maybe 100%. But we recognize that the challenges are both technical in terms of building into the EHR, but also a culture shift requiring a move to a validated screening tool. Thank you to all the teams for your continued persistence with this one. Moving on to treatment. Our women receiving treatment for opioid use disorder at the time of newborn's discharge increased to 63% statewide. This speaks to the continued need to link to pregnant people to substance use disorder treatment prior to delivery, but also speaks to the improvements that we have made throughout the state. Narcan prescription is something that is really near and dear to my heart, and though we are not currently where we need to be in terms of getting Narcan to patients at risk for overdose, we have made really significant improvements with 15 times the number of prescriptions given now than at baseline. So what's great about that is that we are saving lives by getting this medication directly into patients' hands. Next, we're going to shift to our newest project, the Severe Maternal Hypertension Project. We have 7 pilot teams. Our state leads are Dr. Connie Graves and Dr. Danielle Tate, who really have lent their expertise to us. And we launched the statewide project February of 2021. But we had pilot teams that participated in the building of this project, and we are really grateful for that. We look forward to sharing data with you from that project at our 2022 annual meeting. Something else that I'm really excited about are our blood pressure cuff project. This is an offshoot of our hypertension project that we have 7 teams participating in a blood pressure cuff project with the National Preeclampsia Foundation. We are thrilled to be partnering with NPF and look forward to seeing how distribution of blood pressure cuffs to our high-risk patients helps address morbidity and mortality in Tennessee, particularly around hypertensive disorders in pregnancy and postpartum. As an organization, we have committed to focusing on racial disparities to advance the health of all our women in our state. Next slide, please. We launched a health equity series, webinar series that was very well attended across the whole state. And we are so grateful to Dr. Rolanda Lister, Dr. Connie Graves, and Dr. Danielle Tate for being featured speakers for our health equity series. Prior to the pandemic, we started a speakers bureau and trained experts with the intention of holding in-person lectures in their regions. Of course, COVID changed that, and we weren't able to visit you all throughout the state. But many of our presentations have been recorded and are available online, and it's not too late to book a speaker for your institution. Next slide, please. We are also super cool and have a podcast now, 13 episodes and counting on maternal and infant topics. So add us to your podcast list, listen to us on your walks and while you're working out. And before I hand this over to Dr. Murad, I want to thank her for her service as the infant medical director. I've been so lucky to benefit from her wisdom and her expertise, and I look forward to continuing to work with her on future TIPQC projects. Thank you.
Hi, everybody. Thank you, Jessica, for those kind words. I'm going to try to be brief and not repeat some of the information that Jessica has been so kind to share. If we want to go to our first slide. So we had to tackle a pandemic, and it's really hard to run these projects, and not all of our teams were able to fully implement all the aspects of this project, but we still made huge improvements along the way, with teams moving to rooming in model, making improvements in their breastfeeding practices, and discharging more infants home to their biological mother. We had 15 teams, 1,188 babies, and we made a ton of improvement. So I think we can be very proud of the efforts of our teams. I'll go to the next slide. Our Safe to Sleep project has been enrolling data for about the past 7 months. So we have 13 teams on this project, and we've completed 1,571 audits. And this particular project has 4 of the 13 teams who are already seeing an improvement in their percents of audits that are compliant. And we're really looking forward to seeing what this group can accomplish over the next few months. And finally, we have multiple talks and podcasts, as Dr. Young mentioned, and I really would want to hear your ideas for new ones as we go forward into the next year. These are all available at no charge, and the podcasts have 4 infant topics already taped. Thank you for all of our hard work that the teams have done throughout the year, and a special thank you to the TIPQC team who do so much to make this collaborative run smoothly. To continue with our awards, I'm going to turn this over to our Executive Director, our fabulous Brenda Barker.
Well, thank you, and thanks for sticking around for our closing and what you're all waiting for. We'd like to recognize the hospital teams who've worked diligently throughout the year, even with the challenge of a pandemic. Please congratulate these teams on all their accomplishments. The teams participating in our OUD and OEN projects are listed on your screen. Those in green participated as infant teams only. The remainder were both infant and maternal teams. These team members all received the TIPQC pin that you see on your slide at the November learning session. It was mailed to them. It wasn't actually in person, but they did receive them. To receive the highest recognition, teams that had to participate in learning sessions, monthly huddles, turn in leadership reports, participate in coaching calls, collect data, and implement the identified measures. The winners will be revealed in just a moment. The 13 teams that participated in the Safe to Sleep project are listed. This project will continue through the summer. Milestone awards were given for the same criteria as the OUD, OEN projects. Again, congratulations to the teams, and watch the award video to learn the results of their hard work. Finally, I'd like to recognize the 39 hospital teams who participated in the Vermont Oxford or Vaughan Universal NAS training. These teams had their core members complete 18 mini modules. And just today, got new data that as of last month, we had 2,260 individuals take over 18,366 courses. Congratulations on all the teams whose core members have completed all the modules and have received the designation of the Vaughan NAS Center of Excellence. Each of these teams have received a banner, and I would love to share who they are. East Tennessee Children's Hospital, Methodist Le Bonheur Germantown, St. Francis Hospital at Bartlett and Memphis, St. Thomas Midtown, River Park and Rutherford, TriStar Hendersonville Medical Center received the award first, and just today, I found out at 3 o'clock, Williamson Medical Center is also added to this list. Congratulations to all those teams. You still have until the end of June to complete this training if you are planning on it or want to add additional folks. Of course, none of this would be possible without the people of TIPQC working behind the scenes. We're deeply grateful to our state project leaders, and these are all volunteers, Mike DeVoe for his OEN project, Jessica Young, double duty there, as the OUD project, and Dr. Courtney Gutman is the Safe to Sleep project leader. In addition, Connie Graves and Danielle Tate have been our leaders of our hypertension development, and we will give them lots of accolades next year as well. I also can't thank enough our TIPQC staff, Steve Compton, Terry Scott, Bonnie Miller, Amanda Nally, Patty Scott, and our medical directors, Anna Murad and Jessica Young, who is on the last slide. Amanda Nally was instrumental in this meeting and does an enormous amount of work for our branding, our banners, our annual report, anything that has graphics on it, and we could not have done this without her. We could have, it just wouldn't have looked very good. So thank you so much, Amanda, for all your tireless contributions. And now let's go to the hospitals and see who is receiving a banner and the award for their work.
It's a celebration. Celebrate good times, come on. Let's celebrate. There's a party going on right here. A dedication to last throughout the years. So bring your good times and your laughter too. We gon' celebrate and party with you. Come on now. Let's all celebrate and have a good time. Yeah, yeah. Celebration. We gon' celebrate and have a good time. It's time to come together. It's up to you. What's your pleasure? Everyone around the world, come on. It's a celebration. It's a celebration. Celebrate good times, come on. Let's celebrate. Come on now. Celebrate good times, come on. Let's celebrate. We're gonna have a good time tonight. Let's celebrate. It's all right. We're gonna have a good time tonight. Let's celebrate. It's all right, baby. We're gonna have a good time tonight. Let's celebrate. It's all right. We're gonna have a good. You're simply the best. Better than all the rest.
Good afternoon. My name is Patty Scott. I'm the TIPQC Quality Improvement Specialist for the Infant Projects. It's time to see what you all have voted as the top picks for TIPQC projects in 2022. Drum roll, please. All right. Now, let's look at the maternal projects. For the maternal projects, the top 5 topics are maternal mental health and postpartum depression, perinatal safety, maternal mortality, 4th trimester care, disparities, and hypertension. Now for the infant projects. The top 5, donor milk for all facilities, breastfeeding, skin to skin after C-section delivery and kangaroo care, hypoglycemia, and then NICU care of the extremely low and very low birth weight infant. And this goes along with the golden hour. Again, thank you for voting. The TIPQC Projects Committee and the Oversight Board will be closely evaluating each of these suggestions. It's now my honor to recognize our poster winners for this year. Choosing the winners was a difficult task for our projects committee. We want to thank everyone who submitted work for review. First, let's present the winners for our infant posters. Our second place winner is Melissa Hill and the team from Monroe Carroll Jr. Children's Hospital at Vanderbilt. Their project was decreasing CLABSIs by daily rounding in the NICU. Our first place winner for the infant posters is Stephanie Elston and the team from Hendersonville Medical Center. Their project was interventions to increase exclusive breastfeeding rates in the Well Baby Nursery. Now let's present the winners for our maternal posters. Our second place winner is Dr. Elizabeth Mursky from UT-MCK with her poster on examination of vaginal birth after C-section success rate and counseling. Our first place winner is Ansley Kunith from the Vanderbilt School of Medicine and VUMC with her poster on outcomes of immediate postpartum long-acting reversible contraception complications. Congratulations to all who submitted their work and of course to our winners. Winners, watch for your ribbons. They will be mailed to you.
Thank you, Patty. Congratulations to all of our winners and to everyone who did a poster. It was really wonderful to see all the work that you're doing across the state. Well, don't forget to claim CME if you are interested in that. Thank you for joining us for this year's annual meeting. We really plan on being together next year in person. And we look forward to seeing you hopefully soon at a learning session this summer or fall. Please complete the evaluation at the end of the meeting and let us know how we can improve. And we hope you have a wonderful evening. Thanks again and a wonderful year of improvement. Have a great evening.